Welcome him heartily.
Thank you, Prof. Winty. It is almost lunchtime, so I will move straight into my presentation. I must thank Damien for looking at those consumption levels, because the question is, are we ready to change them? This is the real issue, and of course everything is related to behavior. So this is a behavioral type study which I am going to present. But let me give you some. What I'm going to do is briefly look at the obesity challenge that we have and ask the question whether we need new weapons or we need new strategies. And then not what we can do, not what we should do, but what we must do. And of course, a couple take-home messages. So let me start. This, as you can see, is typical in many families around the world, where the man is obese, the woman is obese, the boy is obese, the baby looks obese, and even the poodle down at the bottom looks obese. I used to think it was a dog, but in fact it's a cat, right? Anyway, the pet is obese. These are some data showing you the trends in overweight and obesity in the Caribbean over several decades. And you can see what is happening. And the gender divide is very stark. Notice the last data we have, the men seem to be catching up quite quickly with the women. And we wait the CARFA data to see if, in fact, the last decade, what the pattern is. But we do have a problem. In Jamaica, from different surveys, some mentioned by Damien, we see the increase from 45 to 60 over a 16-year period. And that is about 1% every year, which means we're going to have 20,000 new persons overweight or obese by December this year in Jamaica. Frightening. And we have to beware, because as Barry told us this morning, central obesity is a major concern, quite apart from overall BMI. And there are several risks of overweight, as you can see there. Notice that most people seem to be happy, and that's what obesity does. You tend to be happy, but you don't sort of recognize the challenge and the risks that you're facing. By the way, this is a taxi in Nairobi, okay? Yeah. So obesity is linked to death, and some data from Jamaica shows the main causes of death. And we see injuries. Those injuries are both intentional and unintentional injuries. So even though at the 7 o'clock and the 8 o'clock news at night, we see all of the crime statistics and we need to be worried about it, it only really contributes about 7% of the deaths. Those above are silent. We only know it when our relatives or our neighbor dies and we hear that this person gone. But these are the statistics. And you notice some of them are in green, the top 4. And because they are so much connected with diet, nutrition, and of course obesity, which is about 6 to 7%. And this is why we need to be really concerned. So we can safely say that it is the most important underlying cause of death in Jamaica. So what can we do? We can curb obesity by looking at particularly trans fats. And we want to reach the rate of 10%. And right now it is about 14%. So we need to knock off about 4%. And that might sound like a small percentage, but that's not easy to do. In terms of sugar, we need to reach about 8%. Where do you think we are? 17%. And these as food disappearance data from FAO Stat on Jamaica. And of course, vegetables, we need to reach 14%. And where do you think we are? No, not that bad. We're about 8. So we know what, but if you put it all together in a pie, basically what we're saying, we need to move this pie, this present pie, over when we put in all the food groups from there to there. All right? And that is a challenge because we have to look at the availability of the foods and the healthy ones, the accessibility, and we have to have people consuming it. So that's really the challenge. In essence, that's what we're all about. How do we do that? That's the next question. So we did a little study where the objective was to establish whether the status quo approach can create major changes to dietary behavior in Jamaica. The specific research questions were, are the stages of behavior change for sugar and fat different between males and females, between obese and non-obese, and between those with NCDs and those without? And I want to thank the Research Development Fund. Dr. Ivy seems to be very, I want you to see that slide, Dr. Ivy. I want to thank the Research Development Fund, the small fund that Cliff Riley knows about and Professor Morrison knows about, for support of this important study. So the stages of change model, which I think most of you, if not all, know about, is really something like this. We go through different stages of change. We have the pre-contemplation, those persons who are not even thinking about changing their behavior. Don't even tell me about it. And then we go into another stage where we call contemplation. Well, yes, maybe. And then we go into preparation, those who are ready to make a change. And then we have those who have changed and those maintenance where they have changed for a long time. So in the context of this study, we're looking at pre-contemplation, not thinking about changing their sugar and fat intake. Contemplation, thinking about reducing their sugar and fat intake within the next 6 months. Preparation, planning to reduce the sugar and fat intake within the next 30 days because you're making a plan. And then we look at those who are eating less than 2 servings of sugar or fat for the past 6 months, and those who have maintained it for longer than 6 months. So that is the framework within which we're trying to understand whether Jamaicans are ready to make a change. So we look at stratified random sampling across Jamaica. We looked at 4 parishes. I'll tell you which ones in a while. We interviewed 1 adult per household, and that adult is between 18 and 69 years. Pregnant, bedridden persons were excluded. We had a total sample of 1,057. And we analyzed using chi-squared analysis of variance and logistic regression. The 4 sites you can see there, most of them from Kingston and St. Andrew, but we also went to the east. We got 70, 165 from Montego Bay area, and also from St. Elizabeth, we got 122. That's how we got the 1057. The research fund wasn't able to us to do it in all the parishes, Dr. Ivy. So what did we find? He's my friend, so I can tease him. All right, so I'll give you some characteristics. Heads of household in terms of gender difference. The mean age was 39, 40 years, not much difference. Ethnicity, as you'll expect, mostly African. Marital status, 51, single. About 24, 25 married, common law, 17%. Education, those who completed primary, completed secondary. So we see we had about 1/4 of the sample that actually completed tertiary education. So we had quite a good group in terms of, if you might call, more informed persons in the sample. So the nutritional status by gender, we had, this is the male-female divide, particularly in the obese area where we have many more females than males. When we look at nutritional status by marital status, notice this, those who are single, if you look at the obese group, and those who are married, those common law, and those who are separated, you see that there was a significant difference among these groups. They call it marital bliss, I guess. You know, you sort of. Yeah. But and that was when controlled for age, because you'll expect married people to be older. When controlled for age, we saw that there is also, and that was independent of age. We saw, as we know, there's an increase in obesity by age. I'm just focusing on the obese category. Now, moving on to the stage of behavior change. Now, when we look at location between urban and rural, and this is interesting, because we find that those who actually, remember, this is the group that started to do something in terms of reducing fat and sugar for a long time. There is a difference between urban and rural. When we look at education status, remember we had a large group, a quarter of them that were completed tertiary. There isn't much difference in education in terms of those who have actually started to do something. But in all of the slides, I want to point out that in all of the slides, what the burden of my presentation today is to show you that most of the persons are in either pre-contemplation or contemplation, either not even thinking about changing or thinking about it but not doing anything in preparation. So you see that depending on education, even independent of education status, there's a large group of persons, over 50% of them, that are not interested in preparation or moving to the other levels. When we look at by age in terms of action, interestingly, we see that as age goes up, there is more persons, the older group, that tended to be, and this is just for sugar and fat intake, and which is interesting in terms of what Damien presented in the older age group. We see an increase in the persons who are willing to make the change or have made the change as age went up. Of course, it might be related to disease as well. But again, we see a large number of persons not interested in making a change. When we look at, this is the overall picture, male, female, not much difference there. Male and female together. If you look at male, not much difference. Female, a little different in terms of the obese state. Those that tended to have more weight, actually more of them were in the action maintenance stage. But as I said in all the slides, you notice the abundance of persons who are not making that move to change or interested. And when we look at so-called normal in quotes, those without obesity, those with obese, and those with that, oh, sorry, I missed one. These are the ones with diabetes, high blood pressure, and high blood cholesterol. There is a difference when you actually have the condition, in terms of a higher number are actually making this change in terms of sugar and fat. Still a large number who are in pre-contemplation, even though they are suffering from these diseases. And when you compare the normal, the obese and diabetes, you see it goes up in that way. Again, a large number not making any change or willing to. So what can we conclude? 55% are not ready to reduce their fat and sugar consumption below two servings. More than 3 times the number of Jamaicans are in the contemplation stage that are in the preparation. Okay? Health promotion programs with strategies that assume that most persons are ready to change their sugar and fat consumption habits are likely to fail. Why I say that is because when you see the material, not only in Jamaica, but in many places, the assumption is that all we need to do is, because these people are ready to change, is a different strategy you have to take for the pre-contemplation, for those who are preparing. So we can't assume that everybody is ready to change, because that is not the case. Not many of them, as you notice, in the preparation stage. So that is, they are likely to fail because the strategy isn't geared. You have to use different strategies to get people even interested in wanting to change. So new weapons or new strategies, given what I just said. And I'm going to use the same slide that Damien used, but in a different way. We all love this slide. Remember that man going up the hill with that boulder that Damien showed? I have it in a different way. But if you want to go to good nutrition from poor nutrition, it's like that stick man pushing that boulder up a hill. And the more he pushes, of course, the more resistance there is. What we have been doing is helping the individual, as Damien pointed out. But what we need to do is to flatten the hill. We need to change the environment. How do we change the environment? That's the question. We know that we usually move from research to public policy. And one of the first things is that we do the medical and the health research and the randomized controlled trials, and then we come up with recommendations, and we have those. We know exactly how many times, as Barry was saying this morning, we have the recommendations from WHO about, 20 minutes, 3 times a week and blah, 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 but Barry, how much you need to do that to compensate for 1 bottle of Coke. But nevertheless, we have the recommendations which are across the board, particularly in schools. We also have the recommendations for diet, okay? How much we should eat and what we should eat, and the dietary guidelines that were produced. And then we move to clinical and care and treatment, health education, national guideline standards, industry involvement, and of course, national policies and legislation that we heard the ministers talking about this morning. Now, the evidence is there. We don't need to do anything about that. We already have the evidence. The guidelines are already set up. We have been helping the individual for a long time, helping that stick man go up the hill, pushing him. But we're not really getting to good nutrition. And my thesis is that we need to flatten the hill. We need to change the environment. And we change the environment by looking at guidelines and standards, involvement of industry, national policies, and legislation if necessary. So we can conclude from the study again, 60% of the population is overweight or obese and rising. We wait to see what the 2017 survey will show, if it will go higher than what we have seen. Large numbers of obese and persons with chronic disease are not willing or able to change their dietary behavior. We recommend that more structural approaches are required to enable behavior change that can halt the tsunami of obesity and its consequences. The education motivational approach needs to be accompanied by strategies which combat the drivers of this obesogenic environment. So it's not that we're knocking the education program out. No, education is critical. It creates demand for either government, industry. So we have to continue getting people more involved to create that demand. But we see that by itself, looking at these data, it is not going to make the big impact. In other words, the status quo needs to change. So what must we do? If you remember, I just take out the bottom part about changing the environment. National guidelines and standards. Let's look at that. We have our food-based dietary guidelines developed, launched, and we're using that, and we have to continue using these guidelines. So we're well on our way. And when we look at the rest of the Caribbean, almost all Caribbean countries have developed their national guidelines. To what extent they're using it is another matter, but we can work on that to move that along. Industry involvement, that's another way of changing the environment. We need to involve the industry. As Minister this morning quite rightly said, you have time to reformulate, you have time to do this before other measures come in place. And this is why we have the Food Industry Task Force to see how we can get the industry to be involved. Our focus in Jamaica is on product reformulation, is on marketing, is on labeling, and also communication and advocacy. So we have to get the industry involved as we are doing. And then the last one is national policies and legislation. As you know, legislation and laws are very friends to public health. We have so many laws that help us in terms of immunization and fuel changes, seatbelt laws, and so on, tobacco. And we need to look at other measures. What about dietary? Perhaps that is something we need to look at. So if we look at what we have been doing in the past, we have been doing a lot of health staff training and public education and looking at schools to some extent, not much in workplaces and community. And you see the first slide, the first arrow is actually looking at where most of our resources and time went. The ones at the bottom are the big ones to change the environment. The fiscal incentives and disincentives in terms of the sugar, in terms of the fast foods, incentives for fruits and vegetables, working with farmers. How can we do incentives and disincentives, taxation and subsidies? This is an area that we have not explored fully. And that's how we change the environment, regulation and standards. So I am proposing that in the future effort, much more needs to be spent at the bottom part so that we can change the environment. So can we prevent those 2,000 obese cases in Jamaica this year? You think so? Yes, I believe so. The question is, are we bold enough to change the environment? The answer is yes? Well, I was saying earlier that my hope is that this symposium can create advocates for a healthier Jamaica and the Caribbean. I don't know what my colleagues on off-site, I think we have over 100 now off-site. I don't know what they are saying to this. Maybe I can hear a resounding yes from them as well. But are we bold enough? And there are a number of things we can do to flatten that hill, to change the environment. And this is what this symposium is trying to explore. I say, let's do it.